The broadcast is now starting. All attendees are in listen-only mode.
Hi, good afternoon, everyone. It's my pleasure to welcome you to Diabetes Sisters Live Class webinar, Candid Discussions about Diabetes and Eating Disorders. My name is Anna Norton. I'm the CEO of Diabetes Sisters, and I will also be moderating today's webinar. I am so excited to welcome Dr. Goebel-Fabbri in leading this important conversation. And we are missing Asha Brown today, who is the founder of We Are Diabetes due to a personal emergency, but rest assured she will be on our conversation when we continue in September. So today, Dr. Goebel-Fabbri will be leading this important conversation because as women that live with diabetes, we are more likely to develop disordered eating patterns or eating disorders. And for many years, this challenge was not addressed by many healthcare professionals or patients. Today, we are very fortunate to work with teams that help us better understand these patterns and help guide us through treatments. I am so excited to welcome Anne, a clinical psychologist and researcher who's dedicated her career to understanding the relationship between diabetes and the emotional toll that sometimes it can take on our lives. Please welcome Anne to lead us on the topic of diabetes and eating disorders. In the meantime, you may ask questions in the webinar. If you send the questions over, we will address them at the end of the webinar. Thank you. Anne, take it away.
Thanks, Anna. So first of all, I just want to thank Diabetes Sisters for inviting me to do this panel, even though it's a panel of one now. And I want to, again, thank you for the interest and taking this topic as seriously as you do. It's, as you pointed out, it's been something that has not been understood very well. And a lot of what I'm going to be talking about, you'll notice, is still somewhat speculative. So I'm going to be talking about the research that's out there, and I'm also going to be speaking from my clinical experience. And what you're going to notice is that there still isn't enough out there. So we need to keep actively highlighting that this is an important women's health issue in both type 1 and type 2 diabetes. So I wanted to start just with the psychiatric definitions of various eating disorders, because I think it's important for people to understand that within diabetes, both type 1 and type 2, there's not just a singular type of eating disorder that affects people. So understanding the whole range is important. I'm not going to go through all the diagnostic criteria, but anorexia is associated with intense fear of gaining weight, even though the person, in fact, is not overweight. They restrict calories to the point where their body is in danger, where it's affecting health. And in fact, it's the most lethal psychiatric diagnosis that exists. The interesting piece is that in type 1 diabetes, oftentimes because patients with anorexia are restricting so much food, and in particular restricting carbs, they may have what I'm putting in quotes, perfect blood glucose values. Not that there's any such thing, but that their values are so low and their A1Cs are so low that, that the healthcare team may not even understand that something dangerous is going on, because from a diabetes perspective, the targets are actually being met. And so it's not until a dangerously low weight actually comes into being that the person may be noticed in terms of what they're actually struggling with. In fact, prior to that, patients may be getting praised and reinforced for all the quote unquote great work they're doing on their diabetes, and it's actually sort of creating more and more of a problem along the way. Sadly, insulin restriction in anorexia is actually not mentioned in DSM-5, and what that is the Diagnostic and Statistical Manual. You can see it at the bottom of the screen, which is what we use to generate diagnoses. Whoops, let me switch this. Bulimia nervosa is what people think of when they think about binge eating and purging. And the important thing is to understand binge eating is defined as eating a larger amount of food than peers would eat under similar circumstances. And the person has to feel like they've lost control over the eating. And at that point, there's so much fear about gaining weight that purging to prevent weight gain is what results. So this can be self-induced vomiting, misuse of various medications, fasting, or excessive exercise. And this is where the diagnosis of bulimia actually would include insulin restriction, this notion of misuse of medications. And it's great, it's very positive, because the psychiatric community has actually identified that as a particular problem in type 1 diabetes since, I believe, since the late 1990s. So that really allowed for more research to be done in this area. What you see as well at the bottom is that what runs throughout all the eating disorders is this deep, deep problem with dissatisfaction regarding weight and shape, and that their sense of self is truly defined by their weight and shape. And you see that in both anorexia, bulimia, and also in binge eating disorder, which is what I'm getting to right now. Here you have an even more defined definition, more clearly defined concept of what binge eating is. And you can see it can include eating much more quickly than normal until uncomfortably full, eating large amounts of food when they're really not hungry, eating alone because of not wanting to be seen, feeling embarrassed eating this amount. And following the binge is this feeling of intense distress, self-loathing, depression, and guilt. And that's what characterizes the type of binge eating that happens within binge eating disorder. What you'll notice is that what's missing is the purging component. So this is what makes it different from bulimia. So Osted is kind of strange sounding term. What it stands for is other specified feeding or eating disorders. And what this is really capturing is the fact that the majority of patients who struggle with eating disorders do not struggle with those three cookie cutter diagnoses that I just talked about. They really land quite often in this category where they may have certain symptoms of anorexia but not other symptoms, or they may have symptoms of bulimia but not quite all of them. And recurrent insulin restriction for calorie purging is also not mentioned in this category of Osted, where, in my opinion, it really should be mentioned. So you all have probably heard of this term diabulimia. And what's important to understand about diabulimia as a concept is that it's not actually a formal diagnosis. So people can't, professional psychiatrists or psychologists can't say this is a person who's struggling with diabulimia. And even within research, we can't really use that term. What researchers have come up with is this ED-DMT1, which of course just totally rolls off the tongue. But that's how people are referring to this phenomenon. And what I think is important about this ED-DMT1 is that it doesn't misconstrue that all eating disorders within type 1 diabetes have to include insulin restriction, have to fall into what we tend to colloquially refer to as diabulimia. So the pros and the cons of having this name. I think the pros are that having a name at all indicates that there are other people who struggle with this problem. So being able to say, you know, I have diabulimia means I'm not the only one, or else I would call it I have Goebel-Fabbri disease. It also, I think, by indicating that people aren't just out there all on their own, it decreases shame and a sense of isolation, raises awareness, creates a way to talk about things with healthcare, and has created in a large part on the diabetes online community, has created a community for women who are struggling with this. And I should say women and men. The problem is there's been very, very little research on men with eating disorders who happen to have diabetes. So the potential problem, though, with diabulimia as a term is that, again, it sort of risks conveying the notion that that the only issue with type 1 and eating disorders is bulimia. And that, of course, is not the case. People with type 1 can have a whole range of eating disorders, and they all occur at higher rates than in the population at large who does not have type 1. And it also sort of, again, going along with this whole range kind of concept, it often gets associated with the symptom of insulin restriction, and not all patients with eating disorders and type 1 actually do restrict their insulin. However, that being said, the problem of insulin restriction is the problem that's had the most significant focus. And so primarily what I will be talking about is insulin restriction in type 1. It's a very dangerous and very powerful symptom of calorie purging. At diagnosis for diabetes, one of the clear-cut symptoms of undiagnosed diabetes is rapid weight loss. And that weight loss, it is because as the glucose is rising in the body attempts to regulate it by urinating out as many calories as it can. The cells are starving. They wind up having to turn to fat and muscle for energy, and this results in that rapid weight loss. So you can see why doing this same thing, sort of turning the clock back to the diagnosis of type 1 functions as a dangerous purge symptom. The problem is it also functions as a trigger to oftentimes diabetic ketoacidosis, which, as you probably know, is a medical crisis, oftentimes requiring intensive care treatment, and it can ultimately be fatal. So this is where I come to saying what a dangerous purge symptom this is. So a lot of people have theorized, why might there be this connection between eating disorders and type 1? And most of this is theory, not necessarily borne out by research or even looked at by research, but there are certain common threads. So puberty is both a diagnostic peak for type 1 diabetes and for eating disorders, just one diagnostic peak, but it's possible that there's something unique about the two sort of potentially striking at similar times, that one sort of fuels the other. Type 1, as we discussed, also presents with that initial weight loss. And what oftentimes happens, depending on how sick the person is at weight loss, at diagnosis, when they come into the hospital potentially to regulate the blood glucose right around diagnosis, they get a lot of fluid and insulin through IV. And oftentimes there's a lot of swelling and fluid retention that happens quite rapidly right at diagnosis as blood glucose gets regulated. And what I think sometimes happens, what I've heard from my own patients, is that right then they've learned insulin just made me fat. Within just a few days, I gained all this weight back. And in fact, the weight is fluid. It's not what I would call sort of true weight. Also, I think there's a certain way that diabetes treatment in and of itself kind of mirrors eating disorders. So that all that attention to meal planning, to portion size, to exercise, to weight, these are actually essential for diabetes management, but at the same time, they can look and start to feel like like an eating disorder kind of mindset. And in fact, I think the old messages that were given to patients by what I'm going to say are very well-meaning nutritionists was there are good foods and bad foods, and you're either restricting the bad foods or you're cheating. And so it sort of involved a lot of moral judgment, and I would argue moral judgment where that didn't even fit. It wasn't fair to patients. The new message, of course, is focused on carbohydrate counting, but still involves portion control. And so what I think the notion is intended to be is that all foods can fit in a meal plan for type 1 diabetes. But I think oftentimes that focus on carbohydrate amount and portion can end up feeling like restriction. I think it depends on how it's taught by the individual nutritionist, and also how it's taken in by the individual patient and also by the family itself. One thing that we also know from the research is that the DCCT, let me just say what the DCCT was, sorry. The DCCT was the Diabetes Complications and Control Trial. It was the largest and longest research study of type 1 diabetes and management of type 1. And it's actually the reason why we now have that goal A1C of 7%. What it was looking at originally was that there was actually a question, does blood glucose level actually matter in terms of the complications? Would it matter if a patient had a 10% A1C versus a 7% A1C? And so at the time, the standard treatment was a target of about 9% A1C, and they compared those folks to folks who were aiming and getting a lot of coaching to get their A1Cs down to around 7. And what they found was that more intensive group, meaning the 7% group, gained around 10.5 pounds more than the standard care group. The thing to pay attention to with those data is that at the time, they did not have the kinds of what I would call designer insulins and management tools that we have today. Pumps were incredibly rare and really rickety. They didn't work in the same sophisticated way that they do now. There were no long-acting basal insulins like Lantus or Levemir. And so NPH was the sort of standard long-acting, and people had to eat to avoid low blood sugar, so sort of eating for the insulin. And because of the tools that were there at the time, that intensive group had very frequent low blood sugars. So they were having to feed their insulin, and people speculate that that's where that weight difference actually came from. So here's some of the research, though. We know that that women with type 1 diabetes have almost 2.5 times the risk of developing an eating disorder than women without diabetes, which is an incredibly heightened risk. We also know from research that was done at the Joslin quite a while ago that 31% of women who were just waiting in the waiting area, who filled out questionnaires, reported that they had omitted insulin for weight loss. Their age range, you can see, is incredibly broad, so that's not the typical range where you would think of an eating disorder necessarily. And I think it's important to understand that these data do not mean that 31% of these women had eating disorders. What they mean is 31% of these women had utilized a very dangerous means for weight loss at some point in their lives. Doesn't mean that it was at the diagnostic severity of an eating disorder, but what I think it means is that, like any other woman in a Western culture, women with type 1 have similar struggles with weight and with body image, and are willing to do dangerous, crazy things to lose weight. I mean, so this is like the diabetes-specific version of like a crazy weight loss fad diet, like these, cleanses or, very low calorie shakes, or you name it, that someone without diabetes might utilize in a really dangerous fad diety kind of way. The problem is that with type 1 diabetes and insulin restriction, there's a very, very strong relationship to microvascular complications. So if women restrict their insulin with regularity, they're at much higher risk for retinopathy, for neuropathy, for nephropathy, so eye disease, nerve disease, kidney disease. And I've seen in my patient population that it also seems like a higher risk for gastroparesis, which is part of autonomic neuropathy, but we don't know that from data. That's just what I've noticed. Now, if you look up again at that 31% of Joslin patients, my colleague and I, Katie Wenger, looked at those same women 11 years later. And we weren't able to follow all of them because we just couldn't find them. I'm in Boston, and we have a lot of university students, and they might move back all over the country and might change their names, and who knows. But we got a large portion. We got about 60% who participated, but we also found people who had died. And we did this national death registry search, and we found that those who reported insulin restriction had a threefold increase of death just during that 11-year follow-up. So what this showed is it's a really high stakes problem in type 1. So what about type 2 diabetes? Unfortunately, way less is understood about eating disorders in type 2. What we know is, and you'll see the term BED right there, that's binge eating disorder. So like the bulimia, but without the purging. What we know is that prevalence rates vary between around 1.4 and 10% in adults with type 2 and 6% in teens with type 2. So a pretty wide range, but still a higher range than you would see in populations without type 2, in fact. Disordered eating behaviors, so those behaviors that wouldn't necessarily be severe enough to meet a diagnosis, may affect up to even 40% of people with type 2. So it's a very common struggle that people with type 2 have with eating disorder behaviors. And binge eating disorder appears to raise the risk of type 2 independently from weight, which is interesting because binge eating disorder is very, very strongly correlated with larger weight, and type 2 diabetes is often correlated with weight. But what this is saying is that binge eating disorder just on its own seems to raise the risk of type 2. Binge eating disorder is possibly associated, and I say possibly because there were research studies that found no association, and there were research studies that did find an association, is possibly associated with higher A1C, higher triglycerides, higher BMI, so body mass index, but also with more hospitalizations occurring at both a younger age and a shorter duration of type 2. So sort of indicating that if there's type 2 in the context, if there's binge eating and type 2 diabetes, it creates a younger, more severe kind of health problem. The gender breakdown remains unclear. There's not a lot of research involving men, but there's some indication that there could possibly be even a higher rate of males with binge eating disorder and type 2. But that was one study, and it's still not particularly clear. There is less weight loss when people are trying for, like let's say, a type 2 diabetes wellness treatment, and weight loss is being sort of prescribed by the physician. If the patient struggles with binge eating, they often are able to lose less weight. They have a struggle with weight. And this is true even with weight loss surgical patients, that 8.2% of weight loss surgery patients had both type 2 diabetes and binge eating disorder, and interestingly, higher rates of that among the men and the African Americans who were weight loss surgery patients, which is interesting. We don't really know much about that, and it's interesting to see because men and minority groups are oftentimes not studied in eating disorder research. So they represent a patient population that we know a heck of a lot less about. Binge eating in adults and teens with type 2 diabetes has also been found to be connected to a lower quality of life and also with depression. So I think what it shows us is that whether we're talking about type 1 diabetes or type 2 diabetes, eating disorders have this larger power to decrease quality of life, increase a sense of depression, perhaps increase anxiety as well, and certainly just a lower self-esteem and impaired health overall. So what always interests me is what are the most effective treatments? How is it that people actually recover? Because I'm a psychologist and I do some research, but I do a lot of patient care. And when my patients would get better, I would ask them, so, what do you think it was that helped? And I would ask them because we know so little. There's been so little treatment research. In fact, there's been some studies on type 1, but 0 studies on type 2. So I would ask them, what do you think helped? And what I kept hearing over and over and over again was, Anne, I just got sick of being sick. And I have to tell you, I would hate it when I would hear that because it didn't give me really an answer. I wanted to know sort of how can I help other people to get motivated and to feel like they need to focus on recovery. And you can't take that, I just got sick of being sick, and sort of insert it into someone else's brain or someone else's life. So I found that kind of frustrating, and so I looked at the research. And here's what we know. There are 4 treatment outcome studies, only 4 in type 1 diabetes. And remember, I said 0 in type 2. And what they've all used is cognitive behavioral therapy, that's CBT. All of them had very small cohorts. So N less than 40 means less than 40 research participants in each of those 4 studies. Not all of them had groups of patients to compare to, so perhaps patients using a different treatment style, or how patients with type 1 and CBT might compare with no diabetes and CBT. Only 1 study involved follow-up. So, okay, maybe the symptoms improve, but what about improve at the end of treatment, but what about how long-lasting symptom improvement is, how robust that recovery is? 2 of the studies utilized outpatient therapy, 1 study used residential therapy, and 1 study used inpatient. And this is the study that is really frustrating because I think it has 0 bearing within the world of American healthcare. The inpatient study, patients stayed in the hospital for an average of 4 months, sometimes quite a bit longer. And this was done in Japan. So the average length of stay in a psych hospital in the United States is between 7 and 14 days, let alone 4 months. So whatever it did to help is not something we can really utilize, unfortunately, in our country. But here's what these 4 studies, they gave us some clues. They found that patients with type 1 and eating disorder had lower recovery rates, increased risk of treatment dropout, so leaving treatment, and that I don't know how they measured this, but they described that patients were less motivated, I guess, to engage in treatment. I'm not entirely sure what they even meant by that. But so what that indicates to me is, okay, there was something about this population that made them harder to treat, but could it have been that they were harder to treat because the treatment itself wasn't modeled after the type 1? That it was like CBT is a standard treatment for eating disorders that didn't have nuances that were tailored to the unique problems of women with type 1 diabetes. So I just wonder about that. I don't, that's just me speculating. What we also know about treatment is that in 2009, a bunch of us got together at this International Diabetes, Eating Disorders and Diabetes Conference, where the goal that we had was to create basically treatment guideline papers. And unfortunately, at the time, they really weren't based on any data or any research, because none of those 4 studies had even come out yet. But we came up with our ideas about best treatment practices based on our own experience. And so those addressed issues of screening for eating disorders. They addressed hospital-based treatments, outpatient treatments, and again, specific to diabetes, the role of the diabetes educator within all of this. I spoke a little bit, this is a really busy slide, I apologize. I spoke a little bit about the possibility that certain standard eating disorder treatments need to be adapted for the unique issues within diabetes. And here's sort of my model of what I think would be helpful in treatment adaptation. So it starts with the premise that folks who have eating disorders and type 1 have potentially all the similar risk factors for developing an eating disorder than folks without type 1. However, because they have 2.5 times the likelihood of developing an eating disorder, what makes them unique is type 1 diabetes itself. And what makes them unique is the way that type 1 is managed. And I would argue the way that type 1 treatment is taught to patients. So you can see at the top that the goal of diabetes treatment, I don't need to say this to you guys, is to try to reach near normal blood glucose ranges. So near as close as possible to the blood glucose ranges of a person without diabetes, which, as you can imagine, as you know, actually is incredibly difficult and probably unrealistic, I would argue. But what also is unique to the treatment is carbohydrate counting, portion control, and dietary restraint. And I think that's another unique factor that may lead to feelings of food deprivation, dietary restraint, resentment, and ultimately to binge eating, which does not always occur, but it can. Some aspects of diabetes treatment may possibly also be associated with weight gain. Again, I'm thinking back to what I said about the DCCT, although people don't believe that that is a risk of the same magnitude anymore with the newer treatments that we have available. But, you know, I think the way that diabetes treatment is taught to patients and taught to families is such that it really encourages perfectionism, that these blood sugars should be as tight as they possibly can, and more often than not, they don't cooperate with that goal, and it can lead to a lot of frustration. And I think it can also lead to depression and anxiety about diabetes management, and the notion that, well, this is impossible, so forget about it anyway. There's also, you know, some negative feelings about weight and shape and fear of weight gain that can be associated here. And then at the very bottom, this is where people get stuck in that pattern of high glycemia, elevated A1C, and insulin restriction as a calorie purge. So I would say, that each of these unique pieces in the model actually need to be addressed separately, and they need to be addressed through the lens of diabetes management itself. Because, for example, I've had patients at eating disorder treatment centers, and the center doesn't really understand the type 1 and doesn't understand the treatment overall, the recommendations, and they're trying to hammer away to the patient. You can't pay attention to the nutrition facts on food labels. You can't pay attention to calories and all the rest of it. Well, that's all fine and good to try to argue to a person with an eating disorder who doesn't have diabetes, but our treatment involves reading food labels and paying attention to carbohydrate counting and that sort of thing. And that's where sort of a standard treatment for an eating disorder can't necessarily meet the needs of a person with type 1. The treatment needs to be adapted along all of these lines. The most important piece, I think, is to develop a team. So a team of treaters. And that might include weekly therapy for the patient by a psychologist or psychiatrist. It may require, specialty inpatient care. It may require a prescribing physician if psychopharmacology for depression or anxiety is required. I always recommend a monthly medical nurse educator nutrition check-in, because lab values and weight checks need to happen. Weight does or does not need to be communicated to the patient. Oftentimes they don't want to know, and I think that's perfectly fine. But because the team has to take their weight concerns seriously, the goal can't be, let's just ignore weight altogether and let this patient gain weight and have their worst fear realized. Close communication between team members is absolutely essential so that everyone's on the same page. And the biggest problem is, okay, so how the heck do you find a therapist who understands word 1 about diabetes? And what I say is, it's extremely hard. And it makes better sense if you can't find someone who understands diabetes the most important thing is that they have eating disorder expertise, and that they be humble enough to know what they don't know and to learn about the diabetes from the medical team. I don't think it's the patient's responsibility to educate the therapist about their own diabetes. The diabetes presents enough of a burden on people, and they should not have to explain their own treatment to a healthcare professional. That just doesn't seem fair. We know that the best outcomes for eating disorders in general happen with the shortest duration and the lowest symptom levels. And that's obvious. Before it gets entrenched, get into treatment as quickly as possible. Safety needs to be focused on immediately in treatment. So people need to learn the signs and symptoms of DKA so that they know when they have to go to the hospital. Sometimes people misconstrue DKA symptoms as, oh, I have like a stomach flu and I'm fine and I can manage this on my own. No way. It's an absolute medical crisis, needs to be handled in the hospital. I think patients already know about long-term complications. I don't think patients ever need to be lectured or that fear tactics should ever be used with people who are struggling in this way. But I think their concerns about long-term complications need to be discussed, if that makes sense. In other words, driven by the patient, him or herself, rather than the healthcare professional who tries to use scare tactics or lecture the person. For outpatient therapy, I think the most important piece, so in other words, if the person is being treated outside of a hospital, the most important piece is they have to come to some kind of willingness and ability to take basal insulin every day, either Lantus or Levemir. That's going to be what prevents the DKA. If they can't adhere to that recommendation, then they're not really safe to be treated outside of a hospital. And they also can't really think well enough to be in treatment outside of a hospital, because we know how elevated glucose at such a high level really shifts a person's ability to think clearly. I think people who struggle with eating disorders struggle with perfectionism as well. And I think a lot of healthcare professionals struggle with perfectionism as well. So I should have corrected that slide. It says the patient's and your own, and that's when I'm speaking to medical people. I apologize about that. It should be the patient's perfectionism and that of the medical team. Because what needs to happen is blood sugar goals and overall self-care goals that are actually realistic for that patient at that time. Those are what need to be targeted. And so I'll give you an example. I had a patient yesterday actually who A1C was, I believe, like 15% when we started to work together. And her average sugars are now sort of ranging in the high 200s, high 300 range. Now, that would strike a person who doesn't understand this kind of eating disorder as a total train wreck in terms of diabetes management. It's so far outside of the target range, but at the same time, that is massive improvement for that particular patient's health. And so it wouldn't have been realistic to say, yeah, your A1C is 15. That's an average glucose of like 500, and I want it to be at 150, right? I mean, I could want it to be at 150, but it's entirely unrealistic. People also need to get treatment if they're actually in a state of depression or having anxiety that's actually diagnosable. So in that sort of situation, they need to have both therapy with a psychologist or other kind of therapist, as well as medication treatment by a psychiatrist. And I always recommend that patients discuss with that kind of medical prescriber that they want to make sure that the meds are weight neutral, because there's such a fear of, if I take a new medicine, it's going to add to my weight gain. And, you know, and then it's not going to be helpful because it won't even wind up being taken. Eventually, a more flexible eating routine needs to happen within eating disorder treatment centers very often, and also in outpatient care. Very often this concept of mindful eating is applied. And what mindful eating is paying attention to hunger and fullness cues and really using those to drive our eating. It's really nice in theory, but I would argue that the problem with it as applied to type 1 is that there are times when a person with type 1 has to eat regardless of hunger, right? So if a person is low, it doesn't matter if they're hungry. Mindful eating doesn't work then. And for some people, if a person is really high, they don't feel comfortable eating. So mindful eating can't work there either. So I would say it's useful, it has a place, but if that's the only tool that is being recommended, I think it falls short. And at the bottom, this just means, basically this just means people need to work on other ways of coping rather than going to their eating disorder behaviors. DBT is just a type of therapy. Because I've worked with a number of patients who will describe to me that one of the things they like about running their sugars high, not just the weight issue, is that it sort of feels like it helps numb out their feelings of anxiety or their feelings of depression. They sort of feel like they're in this like high blood sugar fog that takes some of their emotional pain away. And so finding different ways to cope with that kind of thing is absolutely essential. This goes along with partly the perfectionism, but partly the problem with that fluid retention that I mentioned earlier. So I believe that incremental improvements in diabetes self-care, that's the way to go. That's the way to target things. And that patients themselves and the healthcare providers need to work together to pace things appropriately and to give credit where credit is due for major, major improvement, whether or not it's at the quote-unquote target range for A1C or glucose. So that includes gradually lowering A1C. And what that does is it decreases a new risk that we're becoming more aware of, which is that if you drop A1C too quickly, people can develop what's called treatment-induced complications. So very, very rapid A1C decrease can result in very, very, very rapid problems with retinopathy and oftentimes with nerve pain as well. And I also think that by aiming for smaller goals, it sort of increases trust and collaboration and decreases the perfectionism as well. I'm going to flip right past this. Well, actually, no. I'm just not going to talk about it in great detail. I recently interviewed 25 women in recovery who were incredibly generous with their time and with their stories, and helped me sort of sort through what are some of the ways that people come to recovery and what are some of the ways that they actually come to their eating disorder. And so it's sort of been my attempt at answering that question of, okay, so how do we get more in this picture than just I got sick of being sick? I felt like I needed to understand more. So if you want to understand more about that, shameless plug for my book. It came out last year in February, and you can get it on Amazon and all sorts of other places. Asha's not here, but I did want to mention a little bit about Asha. So Asha is a woman with type 1 diabetes who's the founder and executive director of We Are Diabetes, which is a nonprofit that I'll describe what she does in a second. And she's been very open with the fact that she struggled with an eating disorder and that these are the various things that have helped her: accepting treatment, surrendering to change, embracing recovery, keeping recovery as her long-term commitment, and using her experience to help others. And using her experience to help others is exactly what she does with We Are Diabetes. They make referrals to providers and treatment centers. They give one-on-one mentorship and guidance through the recovery process. And they have a lot of resources for both patients, families, and healthcare professionals. So they have this thing called the Recovery Toolkit, which is actually really cool. And it's like a little booklet explaining issues related to recovery. And there are a lot of resources on their website. So Injecting Hope, because this can be a really hard topic to talk about. One of the women that I interviewed was really, I thought, very realistic, but also very optimistic. And what she said was, there are people that have gone through this and come out on the other side, and they're not amazing people. They're not shiny, happy people. They're just regular people who never felt like they could do it, but did. And I just think that is a great way to end. So if there are questions, I'd love to be able to address them.
Sure. Thank you, Anne. Thank you so very much. And we actually do have questions. I wanted to thank everyone for staying on because we've got over a little bit of time, but we do have some questions. They're very good ones. So I would like to address them over the next maybe 3 to 5 minutes if we can. The first one is, it says, is there any research to indicate that eating disorders can lead to the development of type 1 diabetes, not type 2?
So the answer is no. There are a handful of people, for sure, whose eating disorder predated their diabetes diagnosis, type 1. But there is absolutely zero data to show that any kind of eating disorder promotes type 1 diabetes.
Okay. The next one is...
It doesn't cause it.
Okay. And the next question is about treatment. The question is, where is peer-to-peer support listed as far as treatment for eating disorders?
Peer-to-peer support is, I guess, formally not called treatment because it's by peers. But I absolutely think it's helpful. First of all, support groups can be very helpful, but also what's been great is just the robustness and the positivity and supportive nature of the DOC, the Diabetes Online Community. There are a number of ways that that women are supporting women, either through Diabetes Sisters or through online, different things. And We Are Diabetes, for example, Diabulimia Helpline. There's a Facebook group. So I think all of these things have a lot of merit. And you're right, I should actually make an update to that slide about multidisciplinary team, because you're making an excellent point that it functions in a supportive way. It's just not run by professionals.
Okay, the next question is, are there any reports of stress management along with medical treatment?
Reports on, I'm gonna make an assumption about what the question actually is. There are research studies looking at stress management techniques and diabetes management, both type 1 and type 2. And much of the research has been done predominantly in type 2, actually. And out of Duke University, Dr. Richard Surwitt, S-U-R-W-I-T, and he has run groups teaching people with diabetes how to manage stress differently using yoga, using meditation, mind-body kinds of techniques. And there is some suggestion that it helps with blood glucose management.
Great. The next question, is there any research or do you have any experience with the effectiveness of treating the whole family versus just the patient?
Absolutely. Well, a couple different things. So within, what I would say is within current type 1 diabetes treatment practices, the primary sort of standard of care is if this is a child with type 1, the family has type 1, and the family needs treatment strategies, and they need to be encouraged and supported, and the way that they all talk about diabetes management needs to be coached in such a way that it doesn't become like a blaming, critical kind of engagement. There's a lot of research on family therapy for eating disorders, but there's not anything yet on family therapy for eating disorders in type 1.
Okay,
and
thank you.
It's definitely a research-supported strategy for treating anorexia in particular.
Excellent. The next question is, we just got another one. Thank you guys for asking so many great questions. The next question is, are patient advocates such as Asha Brown from We Are Diabetes and Erin Akers from the Diabulimia Helpline, are they considered part of the medical teams when it comes to the teams that help patients?
Wow, I don't know, because I think it depends on who the medical team is. In other words, for example, I've had patients that I've worked with who are using either Erin or Asha as a support, and outside of therapy, and so I would consider, yeah, they're part of the team, but I can see that some providers might not be as, I don't know, I'm going to say open-minded. I don't know what a better term might be, and wouldn't sort of like quote unquote approve of that.
Okay, a few more. Do the Japanese research that you spoke about, does that show what type of foods were consumed by the patient and any behavioral modification therapies?
It did not have any information about food. That is a great question. And it was pretty general. I would need to pull it out of my file drawer, but it was pretty general, I think, about what particular techniques were being used in the therapy itself. I can say typically in an inpatient setting, a lot of the therapy that's done is group-based and would involve like cognitive restructuring and thought monitoring and food logging and things of that kind, but I don't think they went into that level of detail.
Okay, we have a question from someone with type 2 diabetes. She says, I'm type 2 and do not take medication. It's important for me to restrict refined and simple carbohydrates, otherwise my A1C and blood sugar soar. At the same time, I tend to stay on track, but then I fall into overindulging in carbohydrates. It's not always easy to get back on track. This is a cycle that has gone on for years and years. So what I'd like to do is I'd like to figure out how to stay focused and not go off track. Do you have any advice?
That is one of the $1 million questions, but that is, boy, is that a struggle. You are absolutely not alone in that struggle. I would suggest that that the problem there has to do with a black and white approach. And I think what happens is a lot of these goals of no refined sugar or no refined carbohydrate or no white flour or no this, no that, result in exactly the problem that it's not actually maintainable. Because in everyday life, we eat everyday foods. And I think the biggest challenge is, how do we eat everyday foods in a way that's flexible and in a way that feels like we're not deprived, but we're also not what some people would refer to as overindulging. That it's like moderation, and all of that is really hard to do. But I think it's harder than I think what's harder to do than moderation is deprivation and then swinging into overdoing and then the desperate attempt to get back on track, quote unquote, with deprivation and then swinging again. I think what has to be figured out is what is going to be a sustainable long-term approach for me. And that's going to be different for one person versus another.
Yeah, thank you. Okay, our last question, and this one comes from a healthcare provider. She says, I'm a psychotherapist and I work with adolescents. I'm wondering if there is a way to talk about diabulimia without planting the seed or giving someone the idea to do this. How do you navigate this? I know that all patients are different, but is it better to give information up front to young people? I try to educate parents, but what are your thoughts about talking with young people themselves? And we're talking specifically about insulin restriction.
Yeah. Really tricky question. So I have worked with a lot of providers, and I would consider myself somewhat in this camp as well, who are afraid to discuss it because they don't want to sort of teach the symptom. So I totally understand that fear, but I also think it depends who you're discussing it with and how you're discussing it. So I love that you're talking to family members about it. They need to understand what to look for. I think that's great. They also need to know what not to do, from the perspective like such a focus on food and body discussion and weight and, oh, I shouldn't have eaten that, and oh, do these pants make me look big, and all that whole like culture of dieting and body dissatisfaction within a family has to go. Harder said than done. But I also think that the way I've approached it in my practice is that, people are referred, usually, I don't know why people are referred to this particular practitioner, but people are referred, let's say, for a high A1C and a concern about what's going on with the insulin use, right? So is this person struggling with an eating disorder? Are they struggling with burnout? Is this depression? What is it? And one of the questions then that has to get asked is, and this is how I would phrase it, is, your A1C is high, and that's why people are concerned. That's why, you and I are talking today. And people can have higher A1Cs for any number of reasons. But what it usually indicates is that you're somehow not getting enough insulin into your body. That could be for all kinds of reasons. What do you think's the barrier for you? And then it opens it up, because people can have problems with taking insulin because they're afraid of needles, because they're afraid of hypoglycemia, because they can't afford the insulin, because they want to piss off their parents, and it's a great hot topic, for all different reasons. And then oftentimes, it's a teenager, so they might say, I don't know. And then I will try to articulate any number of reasons, like, well, some people have talked to me about this, and other people have talked to me about that. And sometimes when it's getting narrowed down closer, I'll say, does it ever connect to concerns you have about your body, like wanting to gain weight, wanting to lose weight? And by leaving it open like that, you're not teaching the symptom.
Perfect. That's a great response, and thank you again. So we are out of time, but I wanted to thank everyone again for joining us. Before we sign off, I want to thank you, like I said, for registering and for participating. So many women participated today. Thank you again. We had over 90 people register, and as promised, we've taken all of those registrants and entered them into a drawing for a copy of Anne's book, Prevention and Recovering from Eating Disorders in Type 1 Diabetes, Injecting Hope. Today's winner is Karen Keating. Congratulations, Karen. We'll be contacting you to send out your prize. Please remember, everyone, that all of our webinars are archived on our website at www.diabetessisters.org. Please check online for our next webinar, and also note that we will be having a follow-up of this conversation in September of 2018. Thank you again for tuning in. Have a great afternoon and happy Valentine's Day. Bye-bye.
Thanks, everybody.